The first learning objective is know the physiologic, i.e. functional differences between bone and cartilage. So a question probably would be, list 3 functional differences between bone and cartilage, right? So the best way to study for the midterm would be to look at the course objectives and try to make sure that you understand what it would be. And then imagine the course objective in the form of a question, like Jeopardy. Okay? So take the course objective, imagine it as a question, and then come up with your answer to that question. So I'm not trying to trick anybody, I'm not trying to make it fancy. I'm just saying that this is the stuff that we went over. So if you look at basic growth concepts, there's these learning objectives. Okay, so a fair question would be, describe the concept of remodeling. All right? Describe, because that's what it's going to be. They'll be like, describe this, or list this, or that kind of thing, okay? And the idea, I'm looking for about a really concise paragraph explanation of that thing, right? So there were 7 lectures, I'm pretty sure. Let me see, I don't know what the last one's today. I think there were 7. Yep. There were 8. So there are 8 lectures total. The last one's today, the role of the dentition and facial growth. So there are 8 lectures total. I gave all the lectures, so I'll make up all the questions, which at least now I know that I'll make up ones that have to do with the topics, the learning objectives. Sometimes people that give a lecture didn't always match it exactly. Okay? You'll have 50 minutes for the test. Okay, I think it's given wherever you guys take tests. It's not in this room, I don't think. Okay, it'll be given through Canvas, because they said you could do that, or ExamSoft. It'll be given through ExamSoft, so you'll log into ExamSoft and you'll do it. Okay? So, and then has to be hand graded, so you won't get your grade right away. So don't call me the next day and say, what's my grade? Because people have to read them, right? Right. And so there's 8 topics. Okay, so there'll be, usually what I do is I have 10 questions, okay, and you have to pick 8 questions, and you have 50 minutes, right? So you've got about 5 minutes a question, so you can't write a book, because I don't want to read a book. Just show me that you can answer that question, and I'm going to give you 10 instead of 8, because, well, just in case you freak out on one, you're not sure, you can just skip it. So, and if you do all 10, I'm only going to count the first 8. All right, so look over all 10 first, decide which ones you want to answer, and then start with the one you think is going to be the fastest, and then go, the one I know that exactly, that's 3 points, I'm going to go do that, okay? So that's that, and if there's questions afterwards, or if your people have questions, have your class representative come up and see me about that. Okay. So today, we're going to talk about teeth. Okay? And since we're all dentists, it's something that we should all have an interest in, and we should all have a really good understanding of the teeth, right? Now, I'm going to talk about teeth in a little different way than maybe Roma talks about, or some of the other people that are talking more in terms of dentistry, like a class 2 Malm or Pitts and Fishers and all those sorts of things. But I want to give you a global look at teeth, because teeth, in my mind, are unique in the body. Okay? So teeth are a unique structure in the body, and they're unique because they're the only, hopefully this is going to go off soon, they're the only structure in the body that I can think of that's an actual organ, like a tooth. If we look at a central incisor, okay, this. Roma, look at that. It's pretty good. That's how I learned dental facial morphology. Dental morphology, I took that from Vivicky Nygaard. She was great. Okay, so let's look at an upper central incisor. And hopefully this goes off soon so you can see it better. But you can see it through the development of the brain. So that, if the way I drew the roof, would be what? An upper right central incisor. Interestingly, about teeth, is, unlike any other structure that I can think of, they exist in both a septic and an aseptic environment. So if I say a septic environment, what am I talking about when I say septic environment?
Infiltrated with bacteria.
Exactly. There's bacteria. There can be pathologic bacteria, and there could be commensal bacteria. Right? Has Dr. Weinberg talked to you at all about stuff? Okay, so he mentioned it all, that? Because I know he's pretty passionate about it. So I figured you wouldn't skip the fact that bacteria, a lot of them are good. All right, a lot of them are good. But remember that the tooth exists in an aseptic and a septic environment. So part of the tooth is aseptic. So even though we have commensal bacteria, even though we have a lot of positive benefits, okay, from having microorganisms inhabit our body, okay, in general, we get problems when we get the septic environment contaminating the aseptic environment. So teeth, because they exist at this border, are unique. There's nothing else. Most other structures, organ systems like your heart, okay, it's an aseptic organ. Okay, if you get septicemia, if you get septic contamination in the pericardium, you die. All right, it's a septic and an aseptic system. So most organs like that. If you look at the small intestine and the large intestine, those are septic, right? So the most septic system starts at the mouth and it ends at the other end, okay? And actually, it only in the colon is septic, okay? Because anything that comes out the urethra, anything that comes out through the kidneys is sterile. So even that is, in other words, urine is a sterile filtrate of blood. So that's not really a septic system, even though people think of, since they both are excrement sort of thing, like people think they're both like the same. They're not. Okay? Urine is a sterile filtrate of blood. Okay? Feces is obviously contaminated. So let's look at the tooth and let's look at here. Now, when we look at the tooth, if we look at the inside of the tooth first, the nerve of the tooth in the mature tooth comes in. The nerve of the tooth comes in the apex here, right? So the nerve of the tooth, or what we call the pulp tissue, what is that, septic or aseptic? Pardon me? Aseptic, exactly. So the pulp is an aseptic area, right? So here you've got the aseptic area. Now just outside of the pulp, probably we have a little more enamel there. So in the pulpal system, what tissues are there? What tissues? What do we see? Blood vessels? Okay. Fibers. You get the fibroblasts are everywhere, right? Okay. But what else is there? Nerves. So the nerves are actually here, but they go out into the area of the dentin, right? So the dento-enamel junction is innervated. Okay. And when you get up in here, it's all dentin. Okay. How is dentin different than enamel? They're both structural tissues. They're both calcified tissues. So what do we know about tissues that are calcified, that are like bone? Can they grow interstitially? No. Okay. So can dentin grow interstitially? No. How does dentin grow? Appositionally. right? Dentin grows appositionally, but the only cells where it can live, it can deposit, the only free surface it has is at the level of the pulp. So do you see how dentin, as a calcified tissue, has some things in common with bone? It can only grow at a surface. So dentin can only deposit new dentin on the pulpal side. What do we call that? Secondary dentin, right? Primary dentin is what you get when you get the tooth form, but that secondary dentin is actually a specialized form of remodeling activity, right? It's just the deposition part. There's no resorption. The septic environment of the mouth can contaminate the aseptic portion of the tooth through a process of breakdown of the enamel. Okay, so we have the enamel on the outside of the tooth, then the dentin, and then the pulp. When we get contamination of the septic system into the aseptic system, you're well aware of that process, right? That's dental caries. So the first dental disease that you deal with has to do with the contamination of the aseptic portion of the tooth called the pulp from the septic portion of the tooth, which is the oral environment through the enamel. So I think you're well aware of that, right? Okay, why can't enamel repair itself? Enamel is the only tissue that I can think of in the body that has no capacity to repair itself. Why is that? It's dead because the cells that made it are gone. It's an inert, exactly, it's a true mineral. Enamel is a true mineral in there because the cells that formed the enamel are on the outside and they're lost. So enamel has no capacity to heal itself. I mean, everything else in the human body, every other disease, okay, is either has two outcomes for every other disease. You know, most diseases, 99% of all diseases, are you're going to recover from. Okay, especially infectious diseases. You know, infectious diseases that cause terminal. If you get a virus, you get like the flu, or you get a cold, or you get all these things that you might go to your medical doctor for. I'm going to tell you, you don't even need to go because you're not going to die. All right. Dental disease, though, and caries is not self-limiting, right? Untreated, it always causes pulpitis. Untreated, this always, I don't know why I have to say yes for sure. So, it always causes that you get a progression because of the breakdown of the enamel first through the dentin, and once it gets into the pulp, it's irreversible. Most likely, you can't really sterilize it then. So the first dental disease that we deal with, caries, is caused by contamination of the aseptic pulp by the septic system of the mouth. Now, we know that teeth are suspended in bone, and I'm drawing a section through it because you know it's a three-dimensional structure, right? I mean, the tooth is stuck into the bone, but it's not attached to the bone, is it? When we say alveolar bone, we say the alveolar bone is there to house the teeth. We talked about that in the mandible, right? We said the alveolar bone is there to house the teeth. But it doesn't contact the teeth. Why not? Why aren't teeth just immediately, next to bone? Why aren't they just attached directly?
So the PDL can absorb the forces of crush and forces of...
The PDL is able to act as a shock absorber because what happens to bone under pressure? Resorption. So bone under pressure would undergo resorption. So in order for us to use teeth in order to compress food or to eat or to chew or anything like that, we needed an interface between teeth and bone. So that was the design specifications. Okay, we've got these teeth, and they've got to have some sort of shock absorber, because you can't, otherwise they would cause bone resorption. So we got the bone for the rigid support, and then we've got the tooth, which is rigid, because what's on the outside of teeth here? Cementum, right? So cementum is very similar to bone. It's very similar material, all right? So you've got cement, and then you've got dent, and then you've got the bone. So what are the two choices for this lining material for the sockets of the teeth? What are the two things that we know about? One we already learned about, right? Cartilage. So cartilage could do it, right? Cartilage could do the shock absorber part, because it can be pressure resistant. The problem is that cartilage isn't dynamic enough to allow the teeth to change as the face grows. So instead of cartilage, which would solve, if you were started as an adult, a fully grown person, okay? If you started as an adult, you could have just cartilage lining your teeth. It wouldn't matter, because there's no dynamic change that's going to occur. But because of that, the system that's developed is really interesting, because the periodontal ligament is, I draw it this way, but actually, you know, it's fibers like this crossing and doing those things. So what's sort of unique is that depending upon, I probably should draw it this way mostly. Most of the fibers are oriented this way. Okay, for an upper tooth. So what is the periodontal ligament? What's the function of the periodontal ligament? It supports the tooth, sure, but we could support the tooth with a shock absorber with cartilage. The unique design for the periodontal ligament, and the periodontal membrane it's sometimes called, is that it translates pressure into tension. It translates pressure into tension. So if you put pressure on the tooth, you create tension at this interface between the cementum and the alveolar process, the cementum and the cortices of the teeth. So it's sort of a cool thing that it creates, it transduces, it converts, it doesn't transduce, it converts pressure to tension. And by converting pressure to tension, now you've put tension on the alveolus as opposed to pressure. And by that way, you can then maintain the alveolus, you maintain that attachment. Other thing is, notice that teeth are at a bone surface. So teeth create a bony surface around the entire root. That's a free surface. Now what did we learn the very first day about bone? It can't grow interstitially, it can only grow on surfaces. So, can bone grow on this surface right here? Of course it can. Of course it can. If it was not able to do that, you would have huge malocclusions of the teeth. Because what's happening is the face and the bones are being displaced and remodeling is occurring, that teeth have to adjust to stay in occlusion. So the teeth have to stay to adjust, because imagine what you would have. If you had, remember we said the cranial base, okay? And then you had the maxilla, okay? And then you had the mandible, okay? Like this, all right? And if the teeth stayed the same, the mandible grows twice as much as the maxilla, right? So you'd end up with something like this in the future. The teeth wouldn't come into contact. So the teeth have to be constantly able to move. So natural movement of the teeth is necessary. Natural movement of the teeth. So what direction do teeth naturally move during the growth process? Mesial is one. Mesial drift, it's called, right? Mesial drift. Mesial drift means that over time, the teeth will generally drift towards the front of the mouth, mesially. Okay? Now, no one's exactly sure why that is, The best explanation is that teeth drift mesially in order to maintain contact, because when we were, Stone Age people, okay, we had the problem with the teeth was that they got narrower here at the bottom, okay? So if teeth, when they would wear in between, like this, they would end up with gaps between the teeth from the wear of food, just from abrasion, okay? So that's the one explanation for why teeth are able to move forward in the mouth. Humans are one of the only species that have mesial drift. Chimps don't have it. So, gorillas don't have it. So it's other primates don't have it, dogs don't have it, rats don't have it. All right? Humans are sort of unique in that regard. So, mesially, you guys know about. Mesial drift probably has very little to do with facial growth and development. In fact, mesial drift, and especially late mesial drift of the lower dentition, is the primary cause for crowded lower teeth in humans. Okay, so if you want to know what mesial drift does for humans now, is it makes our teeth get crooked as we get older. Yes?
Okay, well, how bad is this? Let's say someone has braces from age 17 to 19, they finish the series, it looks great. What are they looking at 60?
At 60, they're lower incisors if they don't wear any retainers, their lower teeth will be crooked. That's what I think is my guess, my answer. Most of the time. When you're talking about the human body, you're talking about humans. Look at the amount of variation we have in this room. But if I say generally, lower anterior teeth are getting crooked. So if you want to know what's going to happen to your teeth as you get older, whether you had braces or you didn't, if you were born with perfectly straight teeth, or if you had perfectly straight teeth therapeutically placed upon you, 10, 15, 20 years from now, chances are your lower teeth are going to be crooked. The reason why the lower teeth are going to be crooked is not because the orthodontist didn't do a good job. The reason why is that the orthodontists can only do as good as nature, and people born with naturally straight teeth, when the majority will have crowding of their lower front teeth as they get older. And so that's a natural process. Why is that? Why do people get crowding later? Perfect. Don't let anybody tell you anything else. Okay, if somebody tells you it's the third molars jamming into the back of the dentition, that's ridiculous. All right? This doesn't make any, let me put it this way, there's no evidence at all that anything has anything to do with it other than the natural mesial drift of teeth. The natural mesial drift of the teeth is the main cause of lower anterior crowding. So, teeth, can drift mesial. And I've already said that.
One question back to the mesial drift.
Okay, mesial
So
drift.
it squeezes your teeth out of place because of the side-to-side pressure.
Because when you get to the front, it's lower, because if you get mesial drift in the upper, which you can get, the upper teeth are able to come forward. But most people have a normal overbite, so where do the lower teeth go? They have to crowd, exactly.
And then, so if you have like a built-in lower retainer, over time with the mesial drift, it'll forego the mesial drift in the incisor, so it could squeeze it posterior.
I don't know what happens in that case.
Okay.
I think it would be a great experiment,
Yeah.
because now people put in permanent retainers,
Okay.
and I don't know what the long-term results of those will be. That's a great question, though.
I have one, so.
I know, so we should study you.
All right.
All right, I thought about this, studying the periodontal health and all those things, because I'm not sure what it does. Because we know that the reason why teeth crowd is to prevent like periodontal problems, like, because if they didn't, like, they'd be pushed out through the bone, right? Or they'd have a malocclusion, or you get spaces. So I don't know the answer, but it's a great question. So we should probably have everybody here that has a fixed retainer call me in 10 years. Well, we should do an exam today, check your oral health, and then 10 years from now we can see if it's the same. Because people don't know the answer to that. But that was orthodontist bad solution to mesial drift, was that people wanted to keep their, so we'll just hold them straight. I'm not sure how physiologic that is, but we'll see. We'll see. Other questions on mesial drift? All right, because remember, is mesial drift important in facial growth? No. Okay. But I talk about it because it's one of the ways teeth can move, and a lot of times people ask that question, how do teeth naturally move? Okay? So now the important way, in terms of facial growth and development, the important way that teeth move is towards the occlusal plane. Towards the occlusal plane. So, teeth move mesially, and the upper teeth drift down and the lower teeth drift up towards the occlusal plane. So they maintain the occlusion, right? So as the whole face is changing, the teeth, the upper teeth drift inferiorly and the lower teeth drift superiorly, and they meet at what we call the occlusal plane. The occlusal plane. So, is it possible for the occlusal plane to be modified by normal growth and development? Yes. Because as the face grows, the teeth can adapt. And the upper teeth are moving down and the lower teeth are moving up. Okay? So if you would ask me what's the main therapeutic modality that orthodontists use when they treat patients, it's manipulating vertical dental drift. That's the most common, yes.
Yeah, but if this is sort of a, there has to be some sort of a coordination, because it just seems to be that almost everyone, the cusps fall into the central.
Absolutely, absolutely. So basically what's happening is, what stops teeth from going vertically? What stops this vertical drift? The opposing tooth. Okay? And how do you know this? Okay? You know that it's the occlusion of the opposing teeth that stop the teeth from erupting, okay? Or something is stopping that, okay? Because teeth are going to drift vertically until they meet an antagonist. Okay? So there's two parts to this thing. Remember that when teeth are developing, okay, let's get rid of the mesial drift thing because it's not important for us now. Put that back, okay? The teeth are moving vertically, okay, and to maintain their occlusion. So teeth are erupting until they meet an antagonist. So what if a tooth doesn't, just 1 minute, what if a tooth doesn't have an antagonist? Does it stop vertically drifting? No. When does vertical drift stop? Never. Never. Vertical drift never stops. Vertical drift never stops because we know remodeling doesn't stop. So vertical drift requires remodeling of the tooth alveolus, which can occur throughout life, and vertical drift is a tooth going towards the occlusal plane, and unless it's inhibited by an opposing tooth, it will continue to erupt. And that is why in dentistry, if you have a second molar that is present, so this is like, just say this is like, what, 14 and 15, right? That's how you guys call them. All right, so if 15 is here, 14 is here, and you have the lower molar, notice that in a class 1 occlusion, the upper teeth have an extra half cusp. Okay? So, if I have a missing second molar on the bottom, what happens to tooth number 15? What stops it from vertically drifting? The alveolus, exactly. It goes, and sometimes it even can cause problems because now you've got the alveolus. So you'll see sometimes if this happens, the tooth number 15 is here, number 14 is there, and then you've got, this is 30, right? Okay, because 31 is missing. So you see that this vertical drift occurs throughout life, and it can cause malocclusions when you don't have an opposing tooth. Does that make sense? Yes? Okay. Why, if I'm missing 15 and I have a class 1 molar relationship, why doesn't 31 erupt? Because 14 touches it. Okay? Notice that in a class 1, 14 also hits 31. So we don't see usually lower second molars over erupting because the way the upper dentition fits with the lower dentition, we have an extra half tooth on the upper. So it can prevent the vertical eruption, this aberrant vertical eruption. Yes?
If 15 over erupted, would it be like an exposed root then?
No, because what happens when teeth drift, the bone comes with it. Okay? As long as we maintain the septic and the aseptic separation in the root. Okay? So that brings me to septic, aseptic. Do you know, does Dr. Basada still talk to you guys? How about Dr. Palomo, Lena Palomo?
Both.
Periolomo. Okay. Ortholomo and periolomo. Okay. So, what do you call this? And I drew it in 2 dimensions, but it goes all the way around the tooth. What do you call that structure? The attachment apparatus. You remember that? Have you had it yet? Maybe you haven't. I mean, you're still in the first year. You might learn something in the next 3 years, too. Right? So, but the attachment apparatus, you'll learn mostly in this class. But the attachment apparatus separates the aseptic periodontal ligament portion of the tooth from the septic portion of the oral environment. That's the attachment apparatus. It's a complex fibrous attachment that goes all the way around the teeth. And when you take your periodontal probe and you stick, have you done that? All right. So when you stick a periodontal probe in a sulcus, what stops the probe? I'm assuming that you're gentle. Because otherwise nothing, right? It goes all the way in. But so if you're gentle and you just go until you feel that resistance, what are you feeling with the end of that probe? There you go. The attachment apparatus. That's the $1,000 question right there. They never say that, right? They say, they just looking at pockets. What pockets? I don't know. What you're probing for is where is the attachment apparatus on that tooth, okay? And it should be close to the cemento-enamel junction, right? It's supposed to be, that's where it starts, right? You're only supposed to have, a millimeter or so of sulcus around the tooth. If your probe goes way up, like, 8 millimeters, that's a problem. It's a problem for 2 reasons, okay? One is, once you get breakdown of the attachment apparatus, you start to get infiltration of the septic environment into this aseptic space. And when you get septic invasion here, you get osteolytic activity because the bacteria, they don't know any different from resorbing enamel or bone. They just create acid, right? And acid just eats away calcified material. So what happens is you get the aseptic environment in here and you start to get breakdown of the supporting structure of the teeth that we call the alveolus. And when we get breakdown of the supporting structure, where now the new attachment apparatus is there, okay, what do we call that? Periodontal disease. All right, periodontal disease. So the 2 major diseases that we deal with in dentistry, caries and periodontal disease, both have to do with the aseptic environment contaminating the septic environment. Okay, so what you're looking for when you're taking your probe is you're looking to see where this attachment apparatus is. Okay, now why do I care about this as an orthodontist? Because most of the patients that we have don't have periodontal disease, at least they shouldn't. By the way, do you know the prodromal or the most important symptom? Do you know how for sure you can tell if you have inflammation?
She reacted.
Bleeding on probing. That's if you don't have bleeding on probing, and I'm talking about not probing like super hard. You know, you can always get bleeding on probing if you want to. All right, I'm talking about therapeutic probing, okay? Not like sometimes when you're first starting, right? But I mean, in general, if you see this, it's just like if you see somebody flossing their teeth and they go, you know, doc, every time I floss my teeth bleed. All right, what do you know immediately? They have gingivitis, or they don't know how to dental floss, right? You know, they're doing it so hard they're cutting their teeth. But most of the time, people's teeth bleed, or people say their teeth bleed when they brush their teeth. Why is that? They have gingivitis. That's inflammation. It's easy to explain to them, hey, that's not right. That's inflammation. You got to get rid of that. Now, in orthodontics, we rely on the fact that when we put a force on a tooth, we're using the tooth as a transducer, and this is not going to be on the test, but I like to tell you about it anyway. So when you put a bracket on a tooth, what you're using is you're using a physical force, and you're using the periodontal ligament as a transducer to change mechanical force into biologic signal. That's how it works, right? It's not magic. You put mechanical force on teeth, and it changes, the mechanical force changes that to biologic signal. And then the biology that you already know about now. So what biology is happening here when you're putting this mechanical force on the teeth? Remodeling. Remodeling, it's the same thing. It's deposition and resorption. It's the same stuff. You learned it in the first year of dental school. Doesn't change. That's a good thing about my lectures. You could watch them from a couple of years ago, because mostly what I'm talking about hasn't changed in the last 50 years almost. Well, maybe the 50 years it's changed, but not recently, okay? So the idea behind orthodontic treatment is mechanical force to biologic signal, right? So what's the most common, in the olden days, what was the most common way to transmit mechanical force to teeth? Through metal braces. What's the new way to do it? Invisalign. But you know what? It's the same biology. So it's not like, it's just a different way to transmit mechanical force to teeth to get it transmitted into biologic signal. It does not change the biologic signals. It doesn't change your understanding of remodeling. It doesn't change anything other than now instead of using a wire, I'm using a piece of plastic. That's the difference, okay? So vertical drift is critical to growth and development and keeping the teeth in occlusion. Okay, so vertical drift is critical. Mesial drift is almost non-consequential in terms of our normal facial growth and development. Okay, so if we didn't have vertical drift, we'd be in real trouble. Okay, just a couple of ideas. You know that teeth want to erupt. You know that teeth want to erupt until they meet some force that opposes them. So the force of eruption is not that great, okay? The tooth is drifting. It's not being forcibly extruded, right? Which is why the bone comes with it and the teeth come down. So anytime you see teeth that don't come together, remember we talked at the very first day about diagnosis in dentistry is recognizing patterns and recognizing when a pattern isn't what you expect, okay? So what you expect in a fully grown human is that all the teeth will be erupted and touching another tooth. And if they're not, there's something stopping it, okay? So you have a 7 or 8 year old and you go into the schools. You're still gonna go again, right?
Next year.
Okay, so every year, good. All right, so next year you have something else to look for. One thing, I showed you about the ascending ramus, right? Okay. Second thing to look for when you go there. Most of the kids, their front teeth will touch. Most of the kids, their front teeth will touch. And in some of the kids, their front teeth won't touch. Now, when they don't touch, you've got two options, don't you? They haven't fully erupted, because teeth erupt till they meet someone, okay, meet another tooth. So it could be a partially erupted tooth that doesn't finish erupting. Like, so a 7-year-old that doesn't have a lateral incisor that's in contact, well, that still may be unerupted. A 9-year-old that doesn't have a central incisor in contact, there's some problem, right? There's some problem. And now you first thing you do is you recognize the pattern that doesn't fit. And now you go into like, okay, what are my options for that? So what are the options if you see a tooth that's not erupted or not in contact with another tooth. The first one is that, is it supposed to be erupted at that age, right? So you need to know what's normal for that age. But now you've got to say, okay, it should be erupted, it should be touching. What are the two options? Ankylosis is what I heard somebody. Okay. Ankylosis is when any portion, not the whole thing, any portion of this periodontal ligament, at any small, tiny, little baby, little place, just the smallest thing, you get a firm connection between the cementum and the bone. It's never going to be the whole socket, okay? It's always going to be like a little piece, but it doesn't matter. Okay, it's like you can't be a little bit pregnant, you can't be a little bit ankylosed. Okay, you're either ankylosed or you're not. All right, it's not a little bit. All right, so the effect is the same, right? So that's the thing. Somebody is that tooth ankylosed? You say a little bit, but it's ankylosed or it's not. There's no little bit. All right, and so the problem is, a lot of times, you're not going to see this on an X-ray. You're not going to be able to see it on an X-ray. Why? Because the tooth is three-dimensional, right? And it's probably really likely it's in a spot that you can't see. Plus, the periodontal ligament space is really small. Okay, it's really small. So you're trying to look at something on an X-ray that's hard to see anyway, even on a cone beam, even on a three-dimensional X-ray. So when a tooth is unerupted and you suspect that it's ankylosed, what do? You haven't had that yet, but anyway, okay. You tap on it because it sounds different. Because it's solid and it's not. It doesn't resorb that. What's the other option? Say it's not ankylosed. That's one option. That's stuck to the bone. What's another option it could be? Something else is stopping it. For kids? What do you think that is? Thumb sucking. Sure, that's a classic. That's a classic. Finger sucking, thumb sucking, digit sucking, blanket sucking, lip sucking, okay? Playing too much oboe. Playing too much oboe. But you have to be playing a lot of oboe. Play a lot of oboe. But you'll notice if you would go over to the Cleveland Orchestra and you would look at the oboe players, they'll have a space between their teeth where that oboe goes. Okay? And in fact, you don't see it not much now because not as many people smoke. But in people that were pipe smokers, if they kept the pipe in the same place, they would see a spot where those teeth, didn't come together. Why? Because something else is stopping them. Something else is stopping them. So if you see a kid that anterior teeth don't come together, and you make the diagnosis that they're not ankylosed, but that the problem is there's some sort of habit, what's the treatment? Stop the habit, right? Stop the habit, exactly. And if they stop the habit, because they naturally teeth want to go to the occlusal plane, if you stop the habit, then you're going to correct the problem. So does it require any active treatment? All you got to do is stop the problem. And if the kids are young and they're growing, they outgrow it. We do it all the time. And it's always amazing. And you as the doctor are in a great position. Because the parents have probably been telling them for years and years and years, don't suck your thumb. And they're not going to listen to their parents, all right? But I can tell you that the best thing when you're a doctor, you have that rule, you have that authority role, right? You want to get the kid on your side. And what I've done for 30 years now is the first thing I do is I give the kid a mirror. And I say, and I'm there, and I'm right there, and I give them the mirror, and I say, stick your tongue out without opening your mouth. And they go, and stick their tongue out. And I'll go, you're not supposed to be able to do that. And I'll say, why do you think you can do that? And they'll go, I don't know. And I'll say, something's stopping those teeth from growing in normally. Do you have any idea what it might be? Sometimes they just say no. They actually don't. They have no clue. And then I'll say, I'll tell you what, do you suck on your thumb? Yeah. Right. Put your thumb in there. You see how it goes right there? Yeah. Okay. All right. So you see this and that. This is the problem. And they connect it up. And I'm going to tell you, as weird as it sounds, it happens so often that I'll just say to them, you know what, stopping a habit is really hard. A habit is even harder. but anyway, if stopping a habit is really hard, I said it takes 30 days. You have to stop doing it for 30 straight days. I give them a calendar and I say, whenever you're ready, you try to stop for 1 day, and then you stop for 2 days or 3 days. And the parents will come in like, and I'll see you in 3 months. And the parents will come in 3 months and they go, you wouldn't believe it, the next day he stopped. And he comes in, the teeth are together. And the only other option is they stop, the teeth aren't together, then what do you expect? The tongue. Right? Again, you keep going, all right, you did everything you could do, now your tongue won't behave, we're going to have to train your tongue to go to the roof of your mouth. But I mean, that's the way that works. That's how you apply like the basic biology to clinical care. And so the thing to understand in this class is the basic biology, right? Because that's what you're going to carry forward with you. We're going to get different materials in dentistry, we're going to get different stuff. All right? So the last thing that it always comes up is you see this kid, and this is something you want to be able to recognize because it's a problem. You see this, and I see it once a year at least. You get a central incisor like this. You get another central incisor, it's like right here. You get a lateral incisor, it's right here. You get this lateral incisor, it's right here. Okay? And this tooth, and you look at the lip line, and the lip line's like this. How did that tooth get there? It was ankylosed, and all the other teeth drifted vertically, and that tooth was left behind. Okay? So teeth don't submerge. Okay? All the other teeth change. Dr. J's here. I've been saved. Come on now. Well done. No, you're not early. This is what time you're supposed to stop. This is what I do, yeah. Classes are supposed to go 1 to 1:50, but I started a minute late, so I finished.
What are you doing?
But it's all yours. They're all yours. And I was impressed at how many people you get to come to lecture. I usually like have 4.
Just real quick, you talk about how they come together.
Come on in.
Most people are